12 soldiers trapped on Arctic ice, temperatures dropping to -40 degrees Fahrenheit, and all medical supplies frozen solid. Field medic Anderson had two choices: watch his brothers die from hypothermia and frostbite, or find a way to practice medicine when everything he'd learned said it was impossible. Sometimes saving lives means rewriting the medical textbook. The reconnaissance team had been missing for 72 hours in conditions that killed exposed humans within minutes. Anderson's medical bag contained equipment turned into useless frozen blocks. But those 12 soldiers were counting on someone who refused to accept that frozen supplies meant certain death. In the remote wilderness of northern Alaska, Joint Task Force Arctic conducted advanced cold weather training operations designed to prepare American military personnel for combat in extreme environmental conditions found throughout polar regions where strategic interests required military presence and operational capability. Field medic Sarah Anderson served as the primary medical specialist for reconnaissance operations, with expertise gained through specialized training in cold weather medicine, emergency treatment procedures, and survival techniques essential for maintaining human life in conditions that challenged both medical knowledge and equipment functionality. Anderson possessed 5 years of military medical experience, including advanced certifications in emergency medicine, trauma treatment, and environmental medicine that qualified her for operations where standard medical procedures required adaptation to extreme conditions that could render conventional treatment approaches ineffective or impossible. The reconnaissance team consisted of 12 soldiers conducting surveillance operations across vast Arctic terrain where temperatures routinely dropped below -30 degrees Fahrenheit and weather conditions could change rapidly from manageable to life-threatening. Each team member had completed extensive cold weather training and possessed equipment designed for Arctic operations. Arctic medical operations required specialized knowledge of hypothermia treatment, frostbite prevention, cold-induced injuries, and equipment maintenance under conditions where standard medical supplies could malfunction or become unusable due to extreme temperature exposure that affected everything from medications to electronic equipment. The team's mission parameters included establishing observation posts, gathering intelligence on potential threats, and maintaining communication with base operations while operating independently in terrain where rescue operations would be difficult or impossible during severe weather conditions that frequently isolated Arctic units. Tuesday morning brought routine operations as the reconnaissance team established their observation post in a remote valley where they could monitor approaches while remaining concealed from potential enemy forces. Weather conditions were challenging but manageable, with temperatures at -25 degrees Fahrenheit and clear visibility that enabled effective surveillance operations. Anderson conducted routine medical checks ensuring that team members remained healthy and properly equipped for extended Arctic operations. Cold weather injuries could develop rapidly, requiring constant vigilance and preventive measures that would maintain unit effectiveness throughout their mission duration. At 1,430 hours. Weather conditions deteriorated rapidly as Arctic storm systems moved into their operational area with devastating speed and intensity that exceeded every weather prediction and emergency preparation protocol. Temperature dropped from -25 degrees Fahrenheit to -45 degrees Fahrenheit within 2 hours, while wind speeds increased to levels that made movement dangerous and shelter construction critical for survival. The reconnaissance team implemented emergency shelter procedures using equipment designed for severe weather protection, but the storm's intensity exceeded design specifications for their cold weather gear and temporary shelter systems. Wind speeds reached 60 miles per hour while snow accumulation threatened to bury their position. Anderson monitored team members for signs of cold weather injuries as environmental conditions pushed human endurance beyond safe operational limits. Several soldiers began showing early symptoms of hypothermia despite proper equipment and shelter procedures, indicating that the storm was creating survival conditions that exceeded their preparation. Emergency communication with base operations became intermittent due to weather interference with radio equipment while GPS systems malfunctioned in the extreme conditions. The team was effectively isolated in terrain where rescue operations would be impossible until weather conditions improved significantly. At 1,600 hours, the temporary shelter collapsed under wind pressure and snow load, exposing the entire reconnaissance team to direct weather effects that could kill exposed humans within minutes. Emergency shelter reconstruction was impossible due to wind conditions that prevented handling of shelter materials and equipment. The team scattered to find individual protection among natural terrain features including rock formations and natural windbreaks that provided minimal shelter but prevented immediate death from exposure. However, these survival positions separated team members across a wide area where Anderson couldn't provide centralized medical care. Anderson's first assessment of scattered team members revealed multiple cases of advancing hypothermia, severe frostbite affecting hands and feet, and cold-induced injuries that required immediate medical intervention unavailable under current environmental conditions. Standard medical procedures were impossible due to weather exposure and equipment limitations. Her medical supplies had been exposed to extreme temperatures that rendered most medications ineffective, froze liquid medications solid, and made equipment brittle and difficult to use with the precision required for effective medical treatment. Bandages shattered when handled, for fluids were solid ice, and diagnostic equipment was non-functional. Corporal Martinez showed signs of severe hypothermia with altered mental status, uncontrolled shivering, and coordination problems that indicated dangerous core temperature reduction. Standard treatment required controlled warming, insulation, and monitoring that was impossible without shelter and functional medical equipment. Private Johnson had developed frostbite on both hands and feet with tissue damage that could result in permanent disability or amputation if proper treatment wasn't provided immediately. Standard frostbite treatment required specific temperature control, sterile wound care, and medications that weren't available in functional condition. Staff Sergeant Wilson was experiencing symptoms of cold-induced asthma and respiratory distress that could become life-threatening without proper medication and environmental control. His prescribed inhaler had malfunctioned due to cold exposure, leaving him without essential respiratory support during a medical emergency. Anderson realized that she faced impossible medical conditions where standard treatment protocols couldn't be implemented but patients would die without immediate intervention that exceeded normal medical training and available equipment capabilities. Anderson began developing improvised medical procedures using available resources and adaptive techniques that could provide life-saving treatment despite equipment failures and environmental challenges that made standard medical care impossible. Her military medical training included improvisation concepts, but nothing had prepared her for practicing medicine at -45 degrees Fahrenheit where basic medical principles required complete reimagining. Body heat became her primary therapeutic tool as Anderson used her own core temperature to warm medications, prevent further heat loss in hypothermic patients, and provide controlled warming that could reverse dangerous temperature reduction without causing complications associated with rapid rewarming procedures that could trigger cardiac arrhythmias or other serious medical complications. Anderson's approach to medication management required innovation as most pharmaceutical supplies had become unusable due to freezing. She developed body heat warming techniques using skin-to-medication contact that could restore liquid medications to functional temperature ranges without destroying active ingredients through overheating or temperature shock that could render medications ineffective or potentially harmful. Insulation systems became critical as Anderson created thermal protection using clothing layers, equipment repurposing, and natural material utilization that could provide controlled microenvironments for medical treatment. She learned to layer clothing from multiple team members to create warming stations where medical procedures could be performed with patients maintaining survivable core temperatures. Anderson discovered that shared body heat could create therapeutic warming zones using multiple people positioned strategically to maintain patient temperature while enabling medical access for treatment procedures. This technique required careful coordination and energy conservation to prevent the healthy individuals from becoming hypothermic while providing medical assistance. Sterile procedure adaptation became essential as standard sterile technique was impossible in Arctic conditions. Anderson developed modified sterile procedures using heated instruments, improvised sterile fields created from clean clothing and equipment, and wound care techniques that could prevent infection while accommodating extreme environmental limitations that made hospital standard sterility impossible. Wound care required complete improvisation as traditional bandages and medical tape were unusable due to cold brittleness that made them shatter upon application. Anderson created wound dressings using fabric torn from clothing, secured with improvised ties and strips, while developing techniques for wound cleaning using warmed water and improvised antiseptic solutions. Diagnostic assessment adapted to equipment limitations as Anderson relied heavily on clinical observation, patient history, and physical examination techniques that could provide medical evaluation without functional medical equipment. Her clinical skills became critical for determining treatment priorities and assessing patient improvement without technological assistance. Pain management required creative approaches as standard pain medications were frozen or unavailable. Anderson developed distraction techniques, positioning methods that could reduce pain through improved circulation and reduced pressure points, and psychological support approaches that could help patients cope with pain while medical treatment addressed underlying problems. Anderson's treatment of Corporal Martinez required immediate intervention for severe hypothermia that was approaching life-threatening core temperature reduction. Using body-to-body contact, shared insulation, and carefully controlled warming, she began reversing his dangerous heat loss while monitoring for complications. The improvised warming procedures succeeded as Martinez's core temperature began improving and mental status showed signs of recovery. His shivering became more controlled, coordination improved slightly, and consciousness levels indicated that immediate death risk was decreasing through Anderson's intervention. Private Johnson's frostbite treatment required innovative wound care using improvised sterile techniques and materials that could provide protection while enabling circulation recovery. Anderson used heated clothing and careful tissue handling that could prevent additional damage while promoting healing. Anderson developed techniques for warming frozen medical supplies using body heat and careful temperature control that restored functionality without destroying medications. Pain relievers, antibiotics, and emergency medications became usable again through her improvised warming procedures. Staff Sergeant Wilson's respiratory crisis required improvised medication delivery using techniques that could provide bronchodilator effects without functional inhaler equipment. Anderson created improvised inhalation methods using available materials and medications that could provide respiratory support. Each successful treatment provided Anderson with improved techniques and confidence that her improvised medical procedures could save lives despite impossible environmental conditions. Her medical knowledge, combined with creative problem-solving, was enabling effective treatment where standard procedures would have failed completely. Anderson's sixth patient, Specialist Rodriguez, had developed severe cold injuries affecting his feet with tissue damage that normally would require hospital-level treatment. Using improvised techniques, she provided wound care and circulation restoration that could prevent permanent disability. The systematic approach Anderson had developed enabled her to maintain medical care for multiple patients while adapting techniques based on available resources and individual patient needs. Each soldier received specialized treatment despite the challenging conditions and equipment limitations. Anderson created warming stations using body heat sharing, improvised insulation systems, and resource management that could provide therapeutic temperatures for patient care. These stations became centers for medical treatment that enabled more effective care than individual survival positions. Her medical supply management required constant innovation as medications needed to be warmed, equipment required improvised repairs, and treatment materials had to be created from available resources. Anderson's creativity and medical knowledge enabled solutions that seemed impossible under normal circumstances. Weather conditions remained severe throughout Anderson's medical operations, but her systematic approach to patient care was succeeding in reversing life-threatening conditions and providing stabilization that could sustain patients until rescue operations became possible. The morale impact of successful medical treatment provided psychological support for the entire team as soldiers understood that their medic was succeeding in providing effective care despite impossible conditions. Anderson's competence and dedication inspired confidence and determination throughout the unit. Anderson's ninth patient, Private Chen, had developed internal injuries possibly related to shelter collapse that required diagnostic assessment and treatment without proper medical equipment. Her clinical examination skills became critical for determining treatment approaches using available resources while managing the complexity of trauma combined with cold exposure. Chen's symptoms included severe abdominal pain localized to the right upper quadrant, nausea, vomiting, and signs that suggested possible liver injury or internal bleeding. Anderson's physical examination revealed tenderness and possible swelling in the abdominal area, though accurate assessment was difficult due to multiple layers of protective clothing required for survival. The diagnostic challenge required Anderson to rely entirely on clinical skills developed through medical training and experience. She used palpation techniques to assess for internal bleeding, monitored vital signs through pulse assessment and clinical observation, and evaluated mental status changes that could indicate shock or blood loss. Treatment options were extremely limited without surgical capability or advanced medical equipment. Anderson focused on supportive care, including careful positioning to reduce abdominal pressure, monitoring for shock symptoms, and maintaining core temperature while avoiding treatments that could exacerbate internal bleeding through blood vessel dilation. Private Thompson, the 10th patient, presented with severe hypothermia combined with possible spinal injuries from shelter collapse, creating one of Anderson's most challenging treatment scenarios. Spinal injury protocols required immobilization and careful handling, but hypothermia treatment needed aggressive warming that could conflict with spinal protection procedures. Anderson's assessment of Thompson required extremely careful evaluation to determine the extent of possible spinal injury without causing additional damage through examination procedures. She used clinical techniques that could assess neurological function while maintaining spinal immobilization using improvised materials and careful patient positioning. The treatment approach required balancing spinal protection with hypothermia management, creating complex decision-making scenarios where standard protocols for either condition could interfere with treatment of the other condition. Anderson developed modified procedures that could address both issues simultaneously while minimizing risks. Specialist Garcia, the 11th patient, had developed severe frostbite affecting his face and exposed skin areas, combined with early hypothermia that required immediate attention. Facial frostbite presented unique challenges due to proximity to sensory organs and the difficulty of providing effective warming without causing additional injury. Anderson's examination of Garcia revealed frostbite affecting his nose, cheeks, and forehead with tissue damage that had progressed through multiple severity levels. Some areas showed superficial frostbite with skin redness and pain, while other areas had progressed to deep frostbite with waxy, gray appearance indicating frozen tissue. Treatment required careful warming techniques specifically adapted for facial tissue that was more sensitive than extremities. Anderson used gentle warming methods including warm breath, carefully warmed cloth applications, and shared body heat position to warm facial tissue without overheating or causing thermal burns. The combination of cold exposure and trauma created complex medical conditions that required prioritization and resource allocation decisions. Anderson had to determine which patients needed immediate intervention versus which could safely wait for continued treatment as conditions permitted, making life and death decisions based on clinical assessment and available resources. Anderson's medical decision-making required constant adaptation as patient conditions changed and treatment effectiveness needed continuous evaluation. Her experience and medical knowledge enabled appropriate treatment modifications that maintained patient care standards despite resource limitations and environmental challenges that pushed medical practice beyond normal capabilities. The psychological stress of providing medical care under impossible conditions began affecting Anderson's own physical and mental condition, but her commitment to patient care sustained her efforts despite personal exhaustion and environmental challenges that pushed her beyond normal endurance limits. She managed her own stress while maintaining focus on patient care requirements. Anderson developed mental resilience techniques that enabled her to maintain clinical judgment despite extreme stress, physical exhaustion, and environmental pressures that could impair decision-making capability. Her military training and medical education provided psychological tools for managing crisis situations while maintaining professional competence. Private Williams, the 12th and final patient, represented the culmination of Anderson's medical challenge with severe hypothermia, frostbite affecting multiple extremities, and respiratory complications that required all of her accumulated expertise and improvised techniques developed during the emergency period. Williams's condition was the most severe Anderson had encountered, with hypothermia that had progressed to dangerous levels indicated by altered consciousness, irregular pulse, and barely detectable breathing. His frostbite affected both hands and feet with deep tissue involvement that suggested possible permanent disability without proper treatment. The respiratory complications included cold-induced bronchospasm and possible pulmonary edema from prolonged cold exposure, creating breathing difficulties that threatened his survival even if warming treatment succeeded in reversing hypothermia. Anderson had to manage multiple life-threatening conditions simultaneously using improvised techniques. Treatment required Anderson to implement all of her developed procedures while adapting techniques for the most severe patients she had encountered. She used aggressive warming protocols while monitoring for rewarming complications, provided respiratory support using improvised methods, and managed pain and psychological stress through the treatment process. After 18 hours of continuous medical operations in -45°F conditions, weather began improving enough to enable limited communication with base operations and potential rescue coordination. Anderson had successfully maintained medical care for 12 patients throughout the most severe weather conditions, demonstrating medical capabilities that exceeded every prediction for Arctic emergency medicine under extreme circumstances. The weather improvement was gradual but significant, with wind speeds decreasing from 60 miles per hour to approximately 30 miles per hour, temperature rising from -45°F to -35°F, and visibility improving from near-zero whiteout conditions to approximately 100 feet. These changes enabled limited radio communication and potential helicopter operations if conditions continued improving. Initial communication attempts were intermittent due to atmospheric interference and equipment limitations, but Anderson managed to establish contact with base medical personnel who had been monitoring weather conditions and preparing rescue operations as circumstances permitted. The base medical team was amazed by reports of successful patient care under impossible conditions. Anderson provided detailed medical status reports for all 12 patients while continuing treatment using techniques she had developed during the emergency period. Her reports included patient conditions, treatment provided, current status, and evacuation priorities that would enable medical personnel to prepare appropriate continuing care during transport and at base medical facilities. Base medical personnel were astounded by Anderson's success in maintaining patient care under conditions where standard medical procedures should have been impossible. Her improvised techniques and successful treatment outcomes exceeded every expectation for medical care in extreme Arctic conditions, providing valuable lessons for future emergency medicine protocols. The rescue coordination process required careful planning to ensure that patient transport wouldn't reverse medical progress achieved through Anderson's improvised treatments. Medical evacuation procedures needed to maintain warming, continue monitoring, and provide seamless transition from field improvisation to standard medical care without compromising patient stability. Anderson worked with rescue coordinators to establish evacuation priorities based on patient conditions and stability, ensuring that the most critical patients received immediate transport while others could safely wait for subsequent evacuation flights as weather conditions permitted multiple rescue operations. Weather monitoring indicated that conditions would continue improving throughout the next 8 hours, enabling helicopter operations that could evacuate all patients and personnel before weather systems potentially deteriorated again. The rescue window required efficient coordination to ensure everyone reached safety. The rescue operation coordination involved multiple agencies including military medical evacuation, Arctic weather specialists, and emergency medical personnel who would provide continuing care during transport and at base medical facilities. Anderson's detailed patient reports enabled appropriate preparation for complex medical cases. Anderson's medical innovation during the emergency had created treatment protocols that needed to be maintained during evacuation to prevent reversal of medical progress. Her techniques for warming, circulation maintenance, and improvised wound care required continuation during transport using available helicopter medical equipment. Communication with base medical facilities enabled Anderson to provide detailed briefings about each patient's condition, treatment received, and continuing care requirements. Her clinical documentation, maintained throughout the emergency, provided essential medical continuity for hospital personnel who would assume care responsibilities. The psychological impact of successful rescue coordination provided enormous relief for Anderson and all team members who had survived impossible conditions through medical innovation and determination that exceeded normal human capabilities. The knowledge that professional medical care was hours away enabled better stress management and confidence in continued recovery. The rescue operation required 8 hours to evacuate all patients due to weather conditions and terrain challenges, during which Anderson continued providing medical care using techniques that had proven successful throughout her emergency treatment period. Her continued medical supervision ensured patient stability during the transition from field improvisation to professional medical care. Helicopter medical crews were amazed by patient conditions they encountered, finding stable, conscious patients who had survived extreme hypothermia, severe frostbite, and multiple trauma injuries through improvised medical care that had exceeded every expectation for Arctic emergency medicine. Anderson's documentation and patient reports enabled seamless medical handoff. All 12 reconnaissance team members survived their Arctic ordeal with complete recovery and no permanent disabilities despite exposure to life-threatening conditions that exceeded survival predictions and medical treatment capabilities. Anderson's improvised medical care had achieved 100% patient survival under circumstances that conventional medicine considered fatal. Medical evaluation at base hospital confirmed that Anderson's improvised treatment procedures had been medically sound and appropriate for the extreme conditions. Her innovations in cold weather medicine provided valuable knowledge for future Arctic medical operations and emergency procedures that could save lives in similar circumstances. Hospital physicians were particularly impressed by Anderson's systematic approach to multiple patient care, her clinical assessment accuracy without diagnostic equipment, and her successful adaptation of standard medical procedures to extreme environmental conditions that had never been encountered in medical literature. The successful patient outcomes included complete recovery from hypothermia without complications, successful frostbite treatment with minimal permanent tissue damage, and management of trauma injuries that could have been fatal without proper medical intervention. Anderson's medical miracle had saved 12 lives through individual expertise and determination. Recovery timelines varied by patient condition and injury severity, but all team members returned to full-duty status within 6 months of their Arctic survival experience. Several patients required extended rehabilitation for frostbite injuries, but Anderson's immediate treatment had prevented amputations and permanent disability. The medical documentation of Anderson's treatments provided valuable case study material for military medicine, emergency medicine, and Arctic survival medicine that influenced training protocols and emergency procedures throughout military medical services and civilian emergency medicine specialties. Patient testimonials consistently emphasized Anderson's medical competence, dedication, and innovative problem-solving that had enabled survival under conditions where death seemed certain. Her refusal to abandon patients despite impossible circumstances created lasting bonds and profound gratitude among the soldiers she had saved. Anderson received the Medal of Honor, America's highest military decoration, recognizing her extraordinary medical achievement and life-saving performance under conditions that exceeded normal medical capabilities. The citation emphasized her medical innovation, professional competence, and determination that had saved 12 lives through improvised procedures that redefined Arctic emergency medicine. The Medal of Honor ceremony included senior military medical personnel, Arctic survival experts, and family members of the rescued soldiers who provided testimony about Anderson's medical heroism and the impact of her successful treatment on their families and loved ones who had survived impossible circumstances. More importantly for Anderson personally, every rescued soldier understood that their survival had resulted from one medic's refusal to accept that frozen supplies meant medical care was impossible. Her creative problem-solving and medical expertise had enabled treatment where others might have given up, demonstrating the practical meaning of medical commitment and professional competence. Anderson's improvised medical techniques became standard training material for Arctic medical operations, providing improved procedures that could save lives during similar emergency situations. Her innovations influenced military medicine protocols and emergency response procedures for extreme weather operations throughout military medical services. The psychological impact of Anderson's successful medical operations demonstrated that individual medical expertise, combined with determination and creativity, could overcome circumstances that appeared impossible according to conventional medical assessment. Her story inspired military medical personnel to consider extraordinary efforts when standard procedures proved inadequate. Medical schools and military medical training programs incorporated Anderson's case study into curricula covering emergency medicine, environmental medicine, and crisis medicine where standard procedures and equipment might be unavailable. Her techniques provided practical examples of medical adaptation and innovation under extreme circumstances. Anderson's medical legacy extended beyond military medicine to influence civilian emergency medicine, wilderness medicine, and disaster medicine where standard medical infrastructure might be unavailable. Her innovations provided techniques that could save lives when conventional medical approaches were impossible due to environmental or equipment limitations. Research studies analyzed Anderson's medical procedures and outcomes to understand the physiological and medical principles that enabled successful treatment under impossible conditions. Her empirical results provided scientific validation for improvised medical techniques that had been considered theoretically impossible by medical experts. Anderson continued serving in military medical roles while training other medics in improvised techniques and decision-making processes that could save lives during extreme weather emergencies. Her expertise became invaluable for developing medical procedures that exceeded standard capabilities when circumstances demanded extraordinary efforts. The international medical community recognized Anderson's innovations through professional conferences, medical journal publications, and training programs that disseminated her techniques throughout emergency medicine specialties. Her Arctic medical miracle influenced medical practice on a global scale through demonstrated proof that improvised medicine could succeed under impossible conditions, and that's Field Medic Anderson's Arctic rescue story, the medic who practiced medicine when everything said it was impossible. Here at Last Signal Stories, we honor every medical professional who refuses to give up on saving lives. If this story of medical innovation, determination, and never accepting defeat moved you, hit subscribe for more military stories. Drop a comment below, would you have found a way like Anderson? Until next time, stay tuned for The Signal.